All right, once you have a solid working understanding of how we classify various psychological disorders according to the current DSM model, the idea is that we want to classify psychological disorders so that we can treat them. The entire modern field of psychotherapy and psychiatry is predicated on the idea that we have better ways of treating people who are experiencing psychological distress, and we can target treatment to help people as much as possible. Obviously, throughout the history of mental health treatment, we have not always treated those who are suffering from mental health struggles humanely, from a horrible history of trepanation or drilling holes in the skull, or even lobotomies, or keeping people in horribly restrictive straitjackets or boxes like you see here that were meant to keep people from experiencing any sensory input. Obviously, all of these versions of mental health treatment were not the most humane, and some of the worst mental health treatment strategies have been sent to the dustbin of history. We're no longer so trigger happy on doing psychosurgeries and doing horribly invasive or torturous kind of treatment to subject the mentally ill to. Despite the fact that there's still a lot of stigma against people who are suffering from mental health, more and more the tides of history are changing, and we view those who are struggling with mental health as deserving more so of empathy and um, targeted, well studied treatment that is meant to help them and not subject them to further harm, and not meant to just sort of hide them away from society so we don't have to be confronted with these difficulties. In terms of the current approaches for therapeutic treatment, they fall largely under two columns. Any sort of psychotherapy treatment that's meant to have the sufferer of mental illness basically talk through and work with a clinician to try and understand and change their emotions or behaviors or their thinking patterns. So basically, any sort of talk therapy in which you're speaking with someone to try and change something about your psychological experience. Often, therapy needs to occur to properly change the patterns that go into mental illness. Another important tenet of our current approaches for therapy are going to include biomedical therapy. So, this is going to be any psychoactive medication that's meant to act on the psychological or emotional symptoms of mental disorder. Now, a lot of the times, one or the other of these approaches does not exist in isolation, and really effective treatment would really need to include some of both. So, an eclectic approach would use some therapeutic and some biomedical intervention. Most people who are experiencing mental illness will have their most successful treatment outcomes if they have some approach from either of the columns. So, some approach for therapy and some approach for a biomedical intervention. It's not to say that one or the other is wrong or better, it's that often you really need to have multiple practitioners in your life if you're struggling with mental illness to address what version of therapy is right for you and what biomedical approach is right for you. Again, a history of stigma towards those with mental illness has often had people negatively looking at either one of these approaches and basically thinking that those who suffer from mental illness can will themselves out of it, or it's just um, something that is all in their mind, that is to say, not real. Again, more and more it seems that this perspective is changing, which is a good thing. People who are struggling from mental illness are not just making it up. They're not necessarily just doing it for attention. Anyone who's ever struggled with mental illness or known or loved someone that struggled with mental illness knows that it is a really real version of an illness. And just like if you are suffering with a physical health illness, you need people there who can help you understand your treatment options and choose the course of treatment that's right for you. Many mental health conditions can be very, very well managed, enabling people who are struggling to live lives full of health and well being. And in the absence of these interventions, they would be needlessly suffering. So neither one of these uh, necessarily needs to exist on its own. The idea is that anyone suffering from mental illness needs to be able to work through these options, and often the best treatment plan will be a combination of both. I'm going to start by talking about schools of psychotherapy. The most famous schools of psychotherapy fall under a series of classes. There are, of course, other approaches. There's quack psychotherapy out there that is of poor quality. There's psychoanalytic schools of therapy that, despite the fact that empirical evidence does not support their efficacy, you can still find psychoanalytic psychotherapists out there. Most of the best regarded schools of psychotherapy currently offered are going to fall under one of these categories. So one is your humanistic or person-centered therapy. If you remember when we talked about humanistic theories of personality, one of the most famous and influential proponents of the humanistic schools, Carl Rogers, emphasized the need for one to unlock their full potential via the process of self-actualization. So humanistic psychotherapy is going to be very much centered around helping facilitate an individual's journey towards self-fulfillment. Behavioral therapy is more so going to rely on the principles that we learned when we discussed conditioning, classical conditioning and operant conditioning. So classical conditioning, the pairing together of various stimuli to change your responses, or operant conditioning, the usage of different consequences to shape behavior. These principles have been used to great success for certain conditions. And then your cognitive therapy is going to be any therapeutic approach that focuses on changing maladaptive thought patterns. So Aaron Beck, one of the most famous proponents of cognitive therapy, particularly thought that if one could identify the negative thought patterns that occurred in people who were suffering from illnesses that were characterized as having negative thought patterns associated with them, those would be individuals who could benefit most from cognitive therapy. You might be familiar with what we term cognitive behavioral therapy. This is a really famous and very highly regarded and very effective school of therapy that in particular tries to simultaneously change negative, maladaptive, or disruptive thought patterns along with changing the behavioral components that come with experiencing certain illness. Now, no one of these schools is the right one or the best one. The idea is that there are broad classifications of mental illnesses, and there's lots of different ways that an individual could be suffering from various mental illnesses. The idea is going to be finding the treatment approach that works for you, and very importantly, finding the therapist that works for you. Not all therapists are created equal, right? And not all matches between sufferer and therapeutic approach are going to mesh. So again, this is going to be a process of trying to find the treatment plan that works. So I'm going to start by discussing your humanistic therapies. Again, the humanistic therapeutic approach is most famously associated with Carl Rogers. Again, his broader humanistic theory was about healthy development of personality and individuality. The humanistic therapy was the idea that many struggles that people have with mental illness are about failures to attain these higher levels of self-actualization because of struggles that they may have had growing up that impeded their ability to achieve self-acceptance. So the humanistic theory proposes that healthy well-being is achieved by properly going through this process of self-actualization, and mental illness was faltering at any one of these steps, thus impeding the process towards self-actualization. So, as I alluded to, not all therapies are right for everyone. There's pros and cons to all three of the schools that I've mentioned. The idea is to start thinking about why would certain therapies be targeted for or help with certain kinds of disorders. So think about what sorts of illnesses would be best served by a therapeutic approach that focused on healthy personal growth and increased and improved self-awareness and self-acceptance. So the idea is start to think about what disorders might have the sufferers have a limited sense of self-acceptance or a minimal sense of self-awareness that might impede self-actualization. So start to think about what sorts of disorders would be characterized by a failure along this axis, and thus who might stand to benefit from such a therapy. So, humanistic oriented therapy is often called person centered therapy. A lot of features of your person centered therapeutic sessions, it's going to be non directive on the part of the therapist. The therapist would likely wait for your cues and let you be in charge of directing the session. Person centered therapy is going to focus on trying to make sure that the patient is able to be as genuine, encouraged to be as authentic and genuine as possible. Towards this journey towards genuine self acceptance is going to be encouraging what is referred to as unconditional positive regard. This is one of the primary goals of your person centered therapy, to help the patient work towards a sense of self that is positive and that the patient feels they deserve unconditionally. So there are no things about the person, nothing that the person could do that should diminish the positive feelings that they have towards themselves. So the therapist is going to try and model this by accepting the client no matter what they say, no matter what they feel or what they do, and continue to highlight that every person should feel valued and should feel that they are a good person no matter what. This is going to come through being empathetic and really truly listening to what your client has to say. So, active listening, right? Listening to what someone has to say and sort of repeating it back to them to try and invite them to clarify what they feel and encouraging them to reflect on those feelings. So, just being present and really truly letting the client express themselves. So, this is going to be an approach for therapy that is all about trying to help encourage a person to feel like they deserve a positive sense of self worth. Additionally, often in this approach for therapy, the sorts of themes that might come up in the discussion that the clinician will have with the client will be about what experiences they had in life in which they were not able to experience this unconditional positive regard. So maybe growing up with parents or caregivers that made the client feel that their love and care was conditional. So growing up with parents who didn't accept you for who you were and what you wanted to do. These would be the kinds of experiences that would likely come up in person centered therapy. And the therapist would be there to, again, reiterate to the client that they are deserving of love and self esteem no matter who they are and no matter what they do. So, again, a great exercise is to think about what kind of a person could benefit from this therapy. If you're someone who's struggling with depression, which is characterized by a poor sense of self regard, this sort of a therapy might be tremendously beneficial. If you suffer from narcissistic personality disorder, on the other hand, you can imagine that this would clearly not be the right approach. So, this is going to be a therapeutic approach that works for some, not for others. This is the basic model that your person centered therapists would bring in to their perspective and their meetings with clients, right? This highlighting of the unconditional positive regard and making sure that the client knows that they are deserving of it, empathetic listening, and a prioritization of helping the client come to a sense of genuineness and feeling of authenticity. The main goal will be to help the client understand that they are a good person just the way they are, that you are allowed to be who you want to be, and that that is a person deserving of love, respect, and self worth. Now, moving on to your behavioral therapies, which again, it's not that this is better or worse, it's just that this is a different way, a different approach that we have for trying to help people overcome distinct types of mental illness. So, if we're talking behavioral therapeutic approach, this is going to be any therapy that leans on the principles of learning, so your classical or operant conditioning. This is going to be particularly helpful when we want to reduce unwanted responses to stimuli. So if a person is experiencing a sort of a compulsive behavior that is impeding their health or well-being, behavioral therapy, by using the principles of pairing of stimuli or of administration of consequences, can work towards reducing those responses and behaviors that they don't want. A behavioral approach is obviously going to hinge on a theoretical perspective that's a little bit more in doubt of the healing powers of self-awareness and self-acceptance, right? If you're engaging in a behavior that feels compulsive, that you don't want, that you feel like you can't kick on your own, right? A behavioral therapy might be a perspective that sort of admits that people can't sort of always heal themselves, that they need a little bit more of a direction and some external shaping to get their behavior to the place that they want. So, again, think about why there might be some mental illnesses where a behavioral approach and the administration of some external pressures might be particularly helpful, right? Depression might be a disorder where leaning on your self awareness and improving one's sense of self acceptance might be of help. What disorders, on the other hand, might need that external push? So, for example, addictions, phobias, right? Think about why unconditional self acceptance might not be the thing to help someone kick an alcohol addiction or a phobia. So, a lot of the times, behavioral therapies are going to be used and they're going to be useful when the behavior needs some of that external pressure to be eradicated. So, an important technique that is employed in the administration of behavioral therapies is going to be your counter conditioning, right? So initially, someone who's experiencing a phobia or an addiction, right, the idea is a trigger stimulus might evoke a problematic response, something that the person doesn't want to do, but they're sort of doing it in a compulsory way that they sort of can't help. One approach will be to pair that trigger stimulus with a new and incompatible response, sort of artificially at first, and to have that pairing happen again and again, over and over, until the trigger stimulus no longer elicits that problematic response. So think about how this mimics that Pavlovian iterative classical conditioning type of a process. So let's say somebody has a spider phobia, right? They're so afraid of spiders that it is debilitating. They can't even see a picture of a spider without having a panic attack. That, if it rises to the level of impeding their overall functioning, health, and well being, and they want to kick that phobia, the idea is this process could be employed. Again, it's important to note that phobia needs to rise above the level of a basic fear, right? A lot of us are afraid of spiders, but it doesn't keep us from functioning. If you have a phobia that does impede your functioning, this sort of a process might occur, right? Normally, the trigger stimulus, right, seeing a spider or a picture of a spider or hearing the word spider, triggers a problematic response, a fear response, or a panic attack, or an inability to function. The idea is if you start to pair together those stimuli, a picture of a spider or the word spider, with a new response that's incompatible with the previous problematic fear response, like let's say a relaxation uh, pair, right? Every time you see the word spider, you engage in deep relaxation. Something is meant to counteract that fright response. So instead, induce relaxation. The idea is that after a certain amount of time, that pairing starts to override that fearful response, and you'll no longer have that phobic response to whatever used to trigger your phobia. So, the idea is to think about what would constitute a problematic response in counter conditioning, right? Just being afraid of a spider to the point where it causes you to avoid a spider, right? That's not necessarily so problematic that someone might actively seek treatment for it. Okay, what would constitute a problematic response though? The two basic classes of problematic responses are going to be when a harmless stimulus elicits extreme fear or aversion. So, a phobia, maybe a phobia of flying or a phobia of dogs or spiders. The idea is that if you're having this irrational fear response to something that's basically harmless, the behavioral therapy approach is going to rely on exposure. And with the gradual pairing of exposure to the stimulus with, let's say, a relaxation response, eventually you can start to undo that phobic response. Alternatively, a problematic response could be when a harmful stimulus is eliciting positive or approach type behaviors. So this would more so be the case in addictions, right? If someone is addicted to alcohol, they know that approaching alcohol and drinking alcohol is harmful. They know they shouldn't do it, but they are sort of in a compulsive way drawn to it and they are addicted to it. The approach for treating an addiction, on the other hand, is more so going to be aversion therapy. So pairing the addictive stimulus together with an aversive stimuli to the point where eventually the person is no longer drawn to that harmful object. Okay? So exposure therapy is often going to work like this. The therapist is going to gradually guide the patient through a series of more and more close instances of exposure to the previously feared stimuli. The idea is that by going through this guided exposure hand in hand with the therapist, you can learn to be habituated to the previously feared stimuli. So, this is going to be particularly effective if the exposure is going to be going along with a positive stimulus to help induce, let's say, a relaxation response. Okay, so exposure would just be exposing the patient to more and more frightening stimuli and letting them habituate to that experience. This is going to work even better if, as you're going through those exposure trials, you're additionally learning to, let's say, control your breathing or meditate, anything that can induce that relaxation response to counteract that fear response. This is going to have the goal of systematically desensitizing the patient to the previously feared stimuli. So you basically start small and you grow from there. So you would start with something that is sort of as watered down as possible. So let's say you're helping someone overcome a phobia of dogs. You might start with a picture of a dog or the word dog printed on a piece of paper. Then from there, you might work your way up to a stuffed dog, right? As harmless a exposure to a dog as possible. Then from there, you might be in the same room as a dog, and then you would just get closer and closer to the dog and you increase that exposure intensity until the patient can tolerate each of these increasingly intense levels of exposure. So you want to do this gradually. You don't want to go in too hard, too fast. You want to make sure that you're doing this gradually so the patient can acclimate to these increasingly intense exposure experiences. Now, aversion, on the other hand, is going to basically do this in reverse to try and get the patient to not go towards that object that they shouldn't be going towards. So, this is going to be where you do exposure to a stimulus that typically is eliciting that problematic positive response while the patient experiences some form of discomfort. Right? So, thinking about what problematic positive responses we might want to change, right? This is going to be something like addiction, so alcohol addiction. One behavioral treatment approach to try and help someone kick alcohol addiction is going to be by giving the patient a drug that interacts with alcohol such that the patient is going to vomit as soon as they ingest any amount of alcohol. Not like they drink enough and eventually vomit on their own because they're intoxicated. They take a drug that makes it so that as soon as you have a sip of alcohol, you're going to vomit. So, vomiting is an inherently unpleasant, negative experience. The idea is eventually the patient is going to associate even tasting alcohol with vomiting, and it's going to eventually make it so that they don't want to approach alcohol. You could imagine aversion therapy being used to try and help someone kick an eating addiction, right? Typically, eating addiction is continued because the experience of eating is immediately pleasurable, even though in the end the person who is addicted might feel shame or feel badly after the fact. That addiction is maintained because the immediate response to the eating of those foods is pleasure and happiness. So, aversion therapy might, for example, to pair the eating of those foods that need to be avoided with a mild shock therapy. Now, definitely you can imagine that this might not be the most humane way to treat an addiction. It might also not be the best for inducing long lasting change. People can become more and more tolerant to these negative stimuli over the course of time. Okay, so this is basically how the therapy works, but again, think about how this might have a limited long-term effect, despite the fact that it might be immediately beneficial in reducing those unwanted behaviors. Okay, operant conditioning, which if you remember when we learned about learning, is more so about the administration of consequences and letting the person change their behavior after receiving the consequence. So this is going to, for example, rely on what we call behavior modification. So this is going to be when we sort of gradually attempt to shape a client's chosen behavior to ultimately move them in the direction of the more desired behavioral outcome. So desired behaviors would be rewarded with positive or negative reinforcement, and the problematic behaviors would be punished, either with positive or negative punishment. Okay, so obviously this is going to be, the behavioral therapeutic approach is going to be useful, particularly when you're dealing with behaviors that sort of need some external pressure to sort of be kicked, so addictions and phobias. Now, as I alluded to, these are obviously not going to be a sort of a panacea or a cure-all. Some reasons is that we know that basically conditioning only goes so far. We know that cognitions also play a role in our learning and our ability to change our own behavior. So, for example, someone who's addicted to alcohol, that aversion therapy might help get them over the hump of alcohol addiction, but at a certain point, their sort of ability to self reflect on their addiction is going to play a role. So, if they are able to reflect on the fact that they only got sick when they drank the alcohol because there was something that they had ingested to induce that response, they might be able to sort of push past that negative response of not liking to vomit, and they might be able to push past that and continue to ingest alcohol. They sort of know that if they get over that initial unpleasant feeling of being sick, they get to that reward of being able to ingest alcohol, right? So classical conditioning, it can only go so far. As human beings, we're able to reflect and have cognitions over the learning that has taken place, and that can override the strength of classical conditioning. In thinking about operant conditioning, again, if you remember back to when we learned about this, the idea is that there are motivations that we have to engage in various behaviors. So in operant conditioning, it sort of doesn't necessarily take into account that the external rewards may necessarily interact with your intrinsic or extrinsic motivations. So there needs to be a match between the source of the motivation and the source of the consequences, and any sort of a mismatch is going to limit the effectiveness of your operant conditioning. So then lastly, let's talk about your cognitive therapies. Okay? So cognitive therapies are going to be more so geared towards trying to help people alter negative or maladaptive patterns of thinking. So again, think about how this approach for therapy might be particularly useful when someone's mental illness is characterized by negative or harmful patterns of thinking. Okay. Again, you might imagine that something like depression, which, as we learned about with psychological disorders, is characterized by an unhealthy or harmful pattern of cognition. Okay. So, someone with depression might go the person centered route, or they might go the cognitive route. Again, the idea is that as individuals, the way your depression manifests might be different person to person. So choosing the therapeutic approach that's right for you is just going to take sort of trial and error and seeing what works best for you. Famously, Aaron Beck's cognitive therapy is very famously used to great success to help people treat depression because, again, a really powerful symptom of depression are these cognitive distortions. So, these negative patterns of thinking that cause the patient to suffer from an overgeneralization of the negative consequences and the negative things going on in life, and to blame themselves for all the bad things in their life and take no ownership over the good things in their life. So given that this is a really powerful symptom of depression and it's something that greatly harms those who suffer from depression, Cognitive therapy is really going to try and target these sorts of distorted cognitive patterns that lead people to suffer. Okay, so as I mentioned, being depressed and also being anxious, a really prominent symptom of those disorders are going to be these negative thought patterns that sort of spiral out of control and cause people to interpret their lives and their circumstances in ways that are really, really negative and really, really unhealthy. Okay, so the idea is that someone who is depressed, their thinking pattern is characterized by interpreting the events in their lives in certain ways that cause them to suffer. So, for example, if something bad happens to someone who's depressed, they're a lot more likely to think that that bad thing was because of their own internal characteristics. So, if, for example, you lose your job, something that a lot of people experience, someone who's depressed is going to be very likely to think that that event was because of their own internal characteristics, their incompetence, their worthlessness, and then they're going to overgeneralize that internal belief by thinking that their worthlessness is going to transcend to other events outside of the job context. Okay, so the cognitive perspective on depression is going to be that it's not necessarily bad things happening to you that cause your depression. It's the way you respond to and think about those events that characterize your depression. Because we're all going to experience bad things in our lives, but it's this negative thought pattern that characterizes the experience of depression. So, cognitive behavioral therapy is a really famous and often the best approach for helping people who are struggling with depression and anxiety. So, CBT is going to lean both on some principles of cognitive therapy and behavioral therapy to try and help those suffering from depression. So, CBT is going to combine this cognitive approach of trying to shape and change these negative thought patterns with helping to encourage the client to engage in more positive behaviors and to try and basically reset this cycle of negative events and negative thought patterns and try and basically holistically change someone who's suffering's entire way of thinking and entire way of being. This is really the most broadly used approach for psychotherapy. CBT therapists for depression and anxiety, some of the most common mental illnesses that people suffer from. They abound, and often this is the right approach for someone suffering from, in particular, depression and anxiety. This is going to be an approach whereby the clinician encourages the patient to change both their thinking patterns and to stop with the overgeneralization and self blame and internalization of negative events, and also encourage them to change their behaviors and to change their actions, and to basically give the patient the tools to change both. And I'll just end on a note of a approach for therapy that is bad and should never be done. But I wanted to address it because likely you've heard about it. So, conversion therapy is a largely, should be universally, but largely discredited range of therapies that attempt to change someone's sexual orientation. Now, if you're familiar with the history of the DSM, homosexuality actually used to be classified as a mental illness or mental disorder, basically because the cultural conception of being LGBTQ, while previous versions of the DSM were developed, thought that these were basically sexual orientations basically were perverse and did not jibe with the idea of what was an appropriate range of behaviors. Now, hopefully, it's obvious that this was rightfully stricken from the DSM. Hopefully, it's obvious that the field of psychology and psychiatry has moved past this antiquated notion that sexual orientation is a mental illness that needs to be changed, right? We now know that sexual orientation is something that people are born with, that they can't change, and that they don't need conversion. They just need acceptance from society the same way that everyone else does. So, unfortunately, there is a long history of society using psychiatry and psychology to demonize those of sexual orientations that don't fall within the mainstream heteronormative straight sexual orientations. So basically, despite the fact that these conversion therapies have been used and still are not universally outlawed today, there is no empirical evidence that you can change someone's sexual orientation. You might hear an anecdote here or there that somebody went through conversion therapy and changed their sexual orientation. No study has empirically demonstrated that this actually ends up being true. It appears to be the case that the research consistently shows that you're born with your sexual orientation and that you can't change it, and to try and change it only causes more harm to your psychological health and well-being. Now, there's a vast body of evidence, though, indicating that not only is it not effective, it does more harm than good. It increases levels of depression, suicidality, and substance abuse. So, this is a discredited line of therapies. Many states in the United States have worked towards outlawing this version of therapy, but there is no federal law banning the use of conversion therapy, despite the fact that the evidence is clear, it doesn't work, and it just harms people and damages them psychologically. The research is pretty consistent that the only thing people from non heteronormative sexual orientations need are love and acceptance and the ability to be who they are. So most states have not formalized laws outright banning conversion therapy, although some have. But by and large, the research is consistent that no uh, ethical psychologist should be willing to administer any version of conversion therapy on a patient. So the bodies for psychologists that exist in the United States have discredited conversion therapy as a legitimate approach for therapy and have discredited it as something that should be practiced on individuals. Again, the research is pretty clear. Conversion therapy doesn't work and it hurts people. Okay, so I'm going to end it there and I'll pick back up talking about biomedical therapies.